Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Continuing Education, SOCE, Master's Degree Programs, Master of Science, Food Nutrition, MSCDFSM, Revised, MFN 005 Clinical Therapeutic Nutrition, Second Year, Unit-2 Adaptation of Therapeutic Diets, 2.1 Introduction. In the first unit, we discussed the role of a clinical dietitian and the various steps or processes necessary for rendering effective nutritional care. This unit deals with therapeutic diets and the ways in which the normal diet of an individual can be modified to suit therapeutic needs. The clinical dietitian is educated and trained to interpret the science of nutrition to enhance the quality of life of individuals and groups in health and disease. Each diet prescribed for an individual has its own rationale and purpose. You as a dietitian should have the knowledge, skills and attitudes to ensure quality of work. In this unit, we shall learn about different therapeutic diets that are available in hospital for specific disease conditions. Also, we shall deal with the different modes of feeding through oral, enteral and parenteral route. Let us first understand what a therapeutic diet is and what purpose does it serve. Objectives. After studying this unit, you will be able to discuss the purposes of therapeutic diet adaptations, explain the different ways by which the normal diet can be modified to suit therapeutic needs, plan a diet prescription, describe the principles of general hospital diets, normal, liquid and soft diets, and elaborate on the different modes of feeding. 2.2 Therapeutic diets. Therapeutic diets are adaptations of the normal or regular diet. In other words, it is a diet for a patient suffering from a specific disease such as heart failure, hypertension, renal failure, diabetes, etc. Why do you think that the diet has to be changed in these conditions? What changes must be frequently made? These are a few issues which we shall deal in this subsection. Well, you already know that there are certain diseases which can be cured by food or nutrient concentrates, such as deficiency diseases. In diseases such as diabetes, making alterations in the diet can help to control the extent of the disease and prevent the onset of complications. Similarly, in genetic diseases, about which you have studied in Nutritional Biochemistry course, MFN 002, Unit 12, simple dietary modifications can keep a check on the progression of the disease and symptoms which otherwise could be fatal. The disease process also influences both the quality and quantity of the diet. The other aspects that may require changes include meal frequency. These changes result as a consequence of the following reasons: loss of appetite and therefore low intake, feel more hungry and therefore an increase in the intake, and problems with mastication, swallowing, digestion or absorption of food or specific nutrients due to structural and or functional changes leading to changes in types of food that can be tolerated, as well as feeding frequency. Let us next have a look at the purpose of dietary adaptations. Purpose of therapeutic dietary adaptations. A therapeutic diet is a qualitative modified version of a basic nutritious diet which has been tailored to suit the changing nutritional needs of a patient disease condition. The regular or normal diet may be modified for one or more of the following reasons: to maintain or restore optimum nutritional status, to provide rest or relieve an affected organ, e.g. soft or liquid diet in gastritis, to adjust to the body's ability to digest, absorb, metabolize or excrete, e.g. a low-fat diet for fat malabsorption, to adjust to tolerance of food intake by mouth, e.g. tube feeding for patients with cancer of esophagus, to adjust to mechanical difficulties, e.g. soft diet for patients with denture, problems and to increase or decrease body weight, body composition, e.g. high calorie, low calorie, etc. While going through the above points, you must have come across the terms like soft diet, liquid diet, tube feedings, etc. What are these and what do we mean by these? Don't panic, we shall get to know about these terms later in this unit. The modified diet may reduce symptoms, make the patient more comfortable or improve the quality of life. The types of dietary adaptations for therapeutic needs are reviewed next. 2.3 Types of dietary adaptations for therapeutic needs. Normal nutrition is the foundation upon which therapeutic modifications are based. We have already discussed in previous sections about the purpose of dietary adaptations. The adaptations of the normal diet to suit therapeutic needs may take the following forms: change in consistency of foods, such as liquid diet, soft diet, low-fiber diet, high-fiber diet, increase or decrease in energy value of the diet, such as low-calorie diet for weight reduction, high-calorie diet for burns, increase or decrease in specific nutrients or type of food consumed, such as sodium-restricted diet, lactose-restricted diet, high-fiber diet, high-potassium diet, elimination of spices and condiments, such as bland diets, omission of specific foods such as allergy diets, gluten-free diet, adjustment in the ratio and balance of proteins, fats and carbohydrates such as diabetic diet, ketogenic diet, renal diet and cholesterol-lowering diets, rearrangement of the number and frequency of the meals such as diabetic diet, post-gastrectomy diet, diet for peptic ulcer disease, test diets. These are single meals or diets lasting one or few days that are given to patients in connection with certain tests, e.g. the fat absorption test used to determine if steatorrhea is present, change in feeding intervals, i.e. meal frequency. Having reviewed the types of dietary adaptations, next let us get to know the uses of planning therapeutic diets. 2.4 Normal nutrition, a base of therapeutic diet. Normal nutrition is the foundation upon which the therapeutic modifications are based. The primary principle of diet nutrition therapy is that it is based on the patient's normal nutritional requirements. Any therapeutic diet is only a modification of the normal nutritional needs of an individual to suit what his/her specific condition requires. A person's diet is defined as that person's intake of food and drink. All detailed dietary modifications should be presented with choices, clear guidelines, menu guidance and supporting information as to alternatives possible. Patients should be encouraged to understand the key relationship between a food and a diet. The value of a food depends on the amount of nutrient in the food and the frequency with which the food is consumed. Dietary changes necessary are more likely to be followed if clear explanations and simple instructions are provided as to why the diet has to be changed. The recommended dietary allowances, RDA, are often used as a basis for evaluating the adequacy of therapeutic diets. Nutrient requirements specific to a particular disease state or a disorder must be kept in mind when planning the diet. As a dietitian, you also need to remember that an individual's diet is affected by various factors such as lifestyle, income, knowledge, taste preferences, religious beliefs, and various other socio-cultural factors. Failure to account for these could result in an impractical therapeutic diet planning. What is therapeutic diet planning or diet prescription? We will get to know about this in the next section. 2.5 Diet prescription. The diet prescription designates the type, amount and frequency of feeding based on an individual's disease process and disease management goals. The disease may require a calorie level or other restriction to be implemented. It may also limit or increase various components of the diet such as carbohydrate, protein, fat, vitamins, minerals, fiber, phytonutrients or water. Another aspect which the dietetic prescription takes into account includes the economic status, food habits, such as vegetarian, ovo-vegetarian, non-vegetarian, food intolerances, such as lactose intolerance, gluten-sensitive enteropathy, allergy, such as milk, eggs, occupation of the patient and meal timings. Next, let us have a look at each of these. Economic status. It is one of the important practical considerations to be kept in mind while formulating a diet prescription. During an acute illness, a few expensive items may be permissible, but for more prolonged or chronic illnesses like diabetes or peptic ulcer, the recommended foods must be within the means of the patient. Food habits. These must be known so that the diets can be recommended, keeping in mind the food preferences of the patient. Whether a person is a vegetarian or not must be known. If vegetarian, then the degree of vegetarianism should be assessed. For instance, ovo-vegetarians eat egg but no flesh, egg and fish vegetarians eat just egg and fish but not animal flesh. While home vegetarians prefer to remain vegetarian at home but consume meat, chicken at a restaurant or a party. Food intolerances. The intolerances of the patient for specific food items must be assessed. For example, milk may lead to diarrhea in some people while constipation in others. Those with colonic disorders are likely to get flatulence with whole pulses. Hence, while prescribing the diet, the food intolerances must be clearly indicated and known to the dietitian. Allergy. Food allergies manifest themselves as urticaria, abdominal cramps or bleeding, asthma and angioedema. Many are found to be allergic to milk or egg, and these foods may have to be excluded from the diet of the patient, as you will learn later in Unit 6 in this course. Gluten enteropathy, celiac disease, may result as a consequence to gluten, a protein fraction in cereals and millets, sensitivity, and colitis in young children due to milk consumption. Occupation and meal timings. The occupation and the time at which the meal is consumed daily must be considered. A factory worker who works on different shifts requires more detailed information for a peptic ulcer diet than a manager whose hours of work are fixed. Next, let us get to know how assessment of nutrient intake is done based on the patient's state of health. Energy allowance. The patient's requirement for energy varies with the physical activity and physiological condition. For instance, consider a person confined to bed. He tends to consume less than the one undergoing physical exertion. An example of a physiological state that leads to an increase in caloric needs is fever. A diet high in calories is indicated for undernourished patients. They are advised to take more of energy-dense foods such as starchy foods, sweets, cereals, butter and oils. While a low-calorie diet is indicated for all obese patients. The patient is encouraged to eat small and frequent nutrient-dense meals and to avoid calorie-dense foods. These consist of raw and cooked vegetables, fruits, egg, meat, fish, chicken and skimmed milk with a low intake of cereals. An individual's energy requirement can be determined calculating either required number of kcal day or percentage increase over basal metabolic demands. You can estimate the basal energy expenditure B from anthropometric data using the following Harris-Benedict formula. For men, B is equal to 66, 13.7 W, 5H, 6.8 A. For women, B is equal to 655, 9.6 W, 1.85 H, 4.7 A, where W is equal to kg body weight, H is equal to height in cmas and A is equal to age in years. An additional factor is added depending on the activity level of the patient. Another factor may also have to be added if the patient is under physiologic stress. You will learn more about this concept later in Unit 5 in this course. Mild stress, 20% over B, acute infections or burns, may require 100% over basal. You should determine the actual energy requirements based on the assessment of the individual, his/her activity and his/her medical condition. Carbohydrates. Carbohydrates provide bulk to the diet and along with fats, form the chief source of calories. The comparatively inexpensive form of carbohydrates in a high-calorie diet can include chapatis, bread and biscuits. In a low-calorie diet, these must be used sparingly. Protein. Once the energy requirements have been estimated, protein requirements can be addressed. The aim is to achieve nitrogen balance. There are several factors influencing protein requirements, and these include total energy intake, the metabolic state of the patient and protein losses. However, it is important to keep in mind that protein synthesis requires energy. The RDA for protein is 0.8 g to 1.0 g kg body weight for adults. The actual minimum amount of protein needed to maintain nitrogen balance in healthy adults is 0.5 g kg. The requirement varies with specific disease states or protein needs related to specific conditions or illnesses. For instance, a larger amount of proteins may be needed during severe protein wasting, such as enteropathy or extensive drainage from wounds and fistulas. Protein restriction may be needed in acute renal failure or hepatic insufficiency, as you would read later in Unit 15 and 16. Patients who require high-protein diets are encouraged to drink 600 to 800 ml of milk a day. Now, you must be wondering how one can consume such a large portion of milk daily. Can you suggest a few ways by which the patients get the required amount of protein comfortably? Well, this can be done by a number of methods. Of these, one could be giving a different flavor to the milk by addition of coffee, Ovaltine, chocolate, or consuming milk as milkshakes, ice creams, yogurt. Another way could be consuming proteins from a different source such as egg, cheese, sausages, etc. Patients on protein-restricted or low-protein diets include the ones with portal systemic encephalopathy, CRF, etc. In such cases, the diet is based upon a daily allowance of protein foods with an emphasis on high-class proteins. A few examples of low-protein foods include beetroot, carrots, cabbage, mushrooms, tomatoes, turnips, and most of the fruits. Fats. As you are already aware, fats are reservoir of calories. In addition to carbohydrates, fats can also be an important source of needed calories. In certain therapeutic conditions, fat is necessary to prevent essential fatty acid deficiency. A high-calorie diet should contain fatty foods such as cream, butter, ghee and oil, while a low-calorie diet contains a little or no fat. Patients requiring low animal fat diets must restrict their total fat consumption to less than 30% of their energy needs, and ideally to 3 rd of this must be in the form of polyunsaturated fatty acids, PUFA, and monosaturated fatty acids, MUFA. This can be achieved by avoiding foods that are rich in saturated fatty acids, SFAs, such as all fried meats and fish, whole milk, fried eggs, cream, cheese, and nuts, peanuts, coconut, chocolate, butter, etc. While food products such as poultry, white, fish, egg whites, cottage cheese, skimmed milk, wholemeal cereals, fruits and vegetables, wholemeal bread, meringues, plain biscuits and fatless sponge require no restriction. Mineral and vitamins. The requirements for vitamins such as ascorbic acid and B-complex vitamins and minerals such as zinc may need to be increased to promote wound healing. Also, in cases of long-term nutrition support, a careful assessment of vitamin and mineral status is essential to prevent the development of deficit or toxicities. You should consider the following factors to determine an appropriate vitamin and mineral intake. I. The requirements for healthy individuals. 2. Nature of disease and injury. 3. Body stores of specific nutrients. 4. Normal and abnormal losses through the skin, urine or intestinal tract. And V. Drug-nutrient interactions. Next, let us have a look at sodium and potassium. Sodium, Na. In sodium-restricted diets, 50 mmol Na, foods containing high Na content must be avoided and the examples include processed or cured meats, tinned or smoked fish, tinned vegetables and soups, dehydrated and prepacked meals, salted, biscuits, nuts and crisps. There are very low Na diets as well which contain 20 mmol Na. These are much less palatable since no added salt is used at the table or during cooking. Unsalted butter is used and milk is restricted to 250 ml. We will learn more about these diets later in Unit 11. Potassium. Potassium-restricted diets are important for patients with advanced renal failure undergoing conservative treatment or hemodialysis. The high potassium foods such as whole grain breakfast cereals, vegetables e.g. beetroot, beans, broccoli, leeks, mushrooms, spinach, tomatoes, dry and split peas, lentils, fruits e.g. prunes, dates, currants, grapefruit, oranges, banana etc. must be avoided. Vegetables should not be eaten raw, rather they require leaching before consumption. The patients must also be aware of and warned against using salt substitutes, as you will learn later in Unit 16, subsection 16.11.3, Fluids. Fluid diets are given to patients with more advanced dysphagia or fractured jaws. The diet may include fruit juices, thin strained porridge with milk, egg in milk, strained soups, thin milk pudding, ice cream or yogurt. Also, whole protein polymeric, liquid feeds can be given. Since such diets lack bulk and can cause colonic dysfunction, these are available with fiber supplements. A normal healthy adult at rest needs 1800 to 2500 ml fluids day, or approximately 1 ml kcal consumed. If sufficient water is not consumed, it can lead to constipation. Optimal convalescence requires adequate tissue hydration. The water intake must be liberal to ensure passage of light-colored urine. Additional fluids must be added to replace water lost by excessive perspiration, vomiting, diarrhea, tube drainage or other conditions marked by increased water loss. If sufficient water is not obtained through fluid intake and food, it must be supplied parenterally, usually along with electrolytes. Fluid restriction is needed in cases when excretion is impaired, as in acute nephritis and kidney failure. Fluid requirements per day are calculated as 500 milliliters a day to replace the insensible loss in perspiration and sweating plus the volume of urine passed during the previous 24 hours. During certain clinical conditions, such as renal failure, when the fluid intake can be detrimental to the prognosis of the disease, the fluid allowance is calculated by using the formula fluid allowance 24 hours minus 500 milliliters, insensible losses, plus urine output in previous 24 hours, fluid lost due to diarrhea, vomiting, if any. High-fiber diets. The patients are advised to eat high-fiber cereals as whole grain, flour and bread, whole grain breakfast cereals, whole wheat pasta and brown rice, all kinds of fruits and vegetables, with their edible peels. Unprocessed bran can also be added to cereals or soups to give more fiber. Look up Unit 12 for more details on dietary fibers. Gluten-free diet. It is a diet recommended for the patients with gluten enteropathy. Gluten is present in wheat, rye, barley and oats. Thus, foods containing these should not be eaten. A number of gluten-free products are available on prescription, and these include gluten-free flour, bread and biscuits. Unit 18 presents details on this elimination diets. This type of diet is used in a patient with suspected food intolerance, food allergy or Crohn's disease. You will read about this subsequently. In Unit 6, Exclusion Diets, specific dietary exclusion becomes a necessity in case of food allergy or food intolerance. The therapeutic use of such diets requires a detailed discussion between the patient and the dietitian. Each patient is provided with a list of foods that are permissible and avoided. Also, the need of scrutinize the ingredient lists in all convenience and manufactured foods is emphasized. The examples of these diets include wheat-free diet. Here, foods to be avoided are ordinary bread, biscuits, cakes, pastries, pasta and spaghetti and all wheat-containing breakfast cereals. Milk-free diet. As the name implies, all foods containing milk protein must be avoided such as cheese, yogurt, cream, ice cream and butter. Egg-free diet. In this, eggs and all products containing eggs are excluded from the diet such as beef burgers, pies, cakes, meringues as well Bournvita. And Ovaltine. Additive-free diets. Additives here include permitted food colors such as tartrazine, sunset yellow, Pontius 4R and preservatives such as benzoic acid, salicylates etc. Ketogenic diet. It is occasionally used to facilitate the control of epilepsy. Here, the patient is initially fasted for 48 hours and thereafter, half the energy requirement is provided as MCT, medium-chain triglyceride oil. Energy intake from ordinary food must be restricted to prevent the suppression of ketones. Unit 17 presents details on ketogenic diets, diabetic diets. These are therapeutic modifications in the quantity-quality of various macronutrients, particularly carbohydrates. We will read more about this in Unit 12. The discussion so far is focused on diet prescription and the factors which need to be considered while presenting diets. Next, we shall get to know about how to construct therapeutic diets. 2.6 Constructing therapeutic diets. You could do this by either using qualitative methods or quantitative methods. At times, a combination of both may also be required. What do we mean by these methods? How are these carried out? Let us read the following section and find out. We shall begin with the qualitative methods. A. Qualitative methods. This is where you give the individual choices, clear guidelines, menu guidance and supporting information such as advice on suitable manufactured products. You should encourage the patient to understand the key relationship between food and a diet. The value of a food depends on the amount of nutrient in the food and the frequency with which the food is consumed. The various qualitative methods include guidelines issued for healthy eating, the food guide pyramid, list of desirable food choices, and elimination diets. B. Quantitative methods. These are often essential for constructing therapeutic diets. The two ways by which this could be done are as follows. I. Using an exchange system which delivers a fixed amount of nutrient per food portion. An example of this is the carbohydrate exchange system used in planning diets for insulin-dependent diabetics. The desired level of intake is specified and the diet is constructed from an exchange list. 2. Quantifying the portion size of foods and the frequency of their consumption. This diet is constructed from normal-sized portions of foods, but those foods which have the highest content of a particular nutrient per portion are excluded from the diet. We learnt about this aspect earlier also, where we got to know about fat, NA and K restricted diets. We also had a look at the permitted and excluded food items based on their nutrient content. Frequency of consumption of the various types of foods should also be considered. This method is used typically when a diet is a key component of a multifactorial condition, e.g. coronary heart disease, so you are clear about diet prescription and how to construct a therapeutic diet. Next, we shall learn about the routine hospital diets. 2.7 Routine hospital diets. The most common diets that are prescribed or ordered in hospital situations are enumerated in this section and in figure 2.1. Let us review them one by one. Look at the screen. Figure 2.1 Routine hospital diets. 2.7.1 Normal or general diet. This diet is planned to be consistent with the recommended dietary allowances (RDAs) of nutrients and is based on the food groups. It is usually based on cyclic menus planned according to the region, type of hospital and clientele. Nutritional adequacy depends on the patient's selection of food as well as the patient's intake of food. It is the responsibility of the clinical dietitian to monitor food selection and food